All right, here we go. Welcome, Dr. Jeelani. I'll throw it over to you.
Hi, everybody. I'm so glad. Thank you so many of you guys from joining from all over. Very excited to be here. This is, of course, a topic that's very near and dear to me. For those of you who don't follow me, I have a couple social media accounts, more active on my Instagram, where I kind of shared a lot about my own fertility, my journey, and then being a fertility doctor. Our mission here at Kindbody is to make sure we deliver an unparalleled patient experience, also provide you guys with very innovative care and kind of think outside of the box, which is what I needed in my fertility care to build my family and hopefully one beautiful family for you, a community, and one baby at a time. So what we do offer, in addition to fertility care, which most of you know that includes testing on both male and female, IUI, IVF, family building options, embryo banking, LGBT family building options, male reproductive health, and then genetics, which kind of branches off into testing for monosomic or single gene disorders. We also offer a lot of counseling and support, which I think we should really highlight because this kind of fails by the wayside in most patients' journeys. So knowing that wellness and reproductive health kind of go hand in hand, understanding your nutritional status, and then a big focus on mental health and how this kind of plays a huge role in your fertility journey. One of the biggest things that we want to facilitate and make sure we touch on is time in your fertility journey. Sydney and I are going to touch on this before we end this, but really educating you guys and making sure you have access to reproductive health and care in a very timely manner. So how do you have a baby and what do you need to have a baby? Is three important factors. So it's egg, uterus and fallopian tubes, and then the sperm. We're going to touch on how do we test these individually and how they kind of interact together. So let's start with an egg. So as females, we're born with all of our eggs that we'll ever have. So at birth, we have about 2 to 3 million. By the time you hit puberty or when you get your first period, our body has a really good way of kind of selecting the finest. So it gets rid of most of our eggs and we're left with about 300,000. Here and out, every month, our body recruits hundreds of eggs each month, whether or not you're trying to get pregnant, whether or not you're ovulating, whether or not you're on birth control. Our body recruits about 1,000 eggs. We ovulate one egg when you are ovulating, and then we lose all of them. When you're on birth control or when you're not ovulating, your body still recruits thousands of eggs. Then they kind of sit there or go away. And then this continues to happen, and this is known as biological or chronological aging. Next slide. Perfect. So in order to figure out what your ovarian reserve, and I like to refer to this as our timestamp, is currently, what we want you to do is come in on the first 5 days of your period. Any day, one day. You don't have to actively bleeding, but you have to be on what we call baseline, meaning imagine your period as a baseball game. When you're on your period, you're at home base. So we want to know what your body's thinking, just very much like what the batter's thinking. There's 3 blood tests that we do that kind of gives us an idea of how your body's getting ready to hit a home run or ovulate and get you pregnant. So number 1 is your FSH, and think of F for food. So that is your follicle stimulating hormone. That's how much food your body's making to make an egg. Now, if your body's working really, really, really hard, this FSH number is going to be really high. We don't want it to work hard. So ideally, we want this number to be less than 10 at a 5 or a 6 because we still want it to work. The next number we look at is our estrogen. That's a feedback, meaning how happy is our ovary with the amount of food it's getting. We want the ovary to be happy and we don't want it to be crying for attention. So we want this number to be less than 80, between 30 to 50 is ideal. We look at those two as our qualitative measures. Then in order to understand our quantity, meaning how many eggs do we have in our bank account or ovarian account, we look at a marker known as AMH. And that's kind of like the new sexy marker of fertility because it tells us how high our ovarian reserve is. ideally for females in our reproductive age, we want this number for everyone to be about 1. And then we match it to your age-related peers. And most patients in their 30s will fall around a 3 or a 4. Above 5 is high, middle is between 1 and 5, and under 1 is when we start to panic. That's low. We correlate this number then with an ultrasound. This is a vaginal ultrasound. So we go internally right next to the ovary and count the number of eggs. That is your antral follicle count. That's out of the 1,000 eggs, how many eggs has your body bought to bay or at front? And typically this goes hand in hand with your AMH. So if your AMH is very high, then we see a high antral count, such as somebody with PCOS. If our AMH is low, then we see a low antral count. Okay, this is independent of hormones, independent of anything. It kind of just matches your AMH and your antral count. Next slide. So if you look at think of a champagne glass, because some people often wonder, why do I keep getting this ultrasound every month that we're doing treatment? It's because every month this antral count changes. So kind of like a champagne glass, bubble to the top, you take a sip, you get a period, then the next batch bubble up to the top. So every month we're going to test your FSH, your estrogen, and then your antral count. So what happens next? So that's your baseline. Then you get to ovulation, you ovulate, the fallopian tube moves like hair, kind of like this, grabs the egg, and it sits in what we call the ampulla. So it waits for the sperm patiently to come then fertilize it, and they travel down together to then implant in your uterus. So our second set of testing includes testing our uterus and our fallopian tube. Next slide. Why does age matter when it comes to fertility? Now, do you lose all your eggs at age 35? Not really. At age 35 is when we notice the take-home baby rate, also known as fertility, declines. Why does that decline? It's because our quality starts to go down. Our take-home baby rate goes down because our aneuploidy, meaning the number of abnormal eggs, goes up. Okay, so this is more of a gradual thing. So as we get closer to 35, 40, and higher, our number of abnormal eggs goes up, so our fertility starts to go down. Okay, 1 out of 10 females experience low ovarian reserve under the age of 35. So you don't necessarily want to wait till you're 35. If you're trying to conceive, if you're curious about your numbers, you can do your fertility testing anytime. Okay. So this is our aneuploidy. Aneuploidy means abnormality or meaning of abnormal embryo. So you can see by this bar graph here, as we get older, our live birth rate goes down lower because our aneuploidy rate goes up higher, basically meaning that age is the #1 predictor of fertility. So all of these markers, our AMH can be high, but if we're older, our take-home baby rate still goes down. Okay, so at the same time, we'll look for other endocrine abnormalities such as PCOS, also known as polycystic ovarian syndrome. This is a misnomer. Doesn't mean we have cysts, it just means you have a lot of eggs on ultrasound. That can also present with anovulation, meaning no ovulation, and then therefore constant recruitment of eggs. Thyroid or prolactin abnormalities can also present with anovulation or no cycles or irregular cycles. If we have an under-functioning pituitary gland, then we present with what's called hypo, meaning our brain is not making the signal, the food, so then our ovaries are not working. And then this typically presents with eating disorders, aggressive exercise, rapid weight loss or weight gain. And then this can be mistaken for ovarian failure or premature ovarian insufficiency or premature menopause. So how do we test our fallopian tubes in our uterus? This is done typically cycles days 6 through 12, meaning after you're done bleeding, but before we ovulate, because if you're trying, we don't want to disturb an embryo. We take a tiny little catheter like a noodle, we slide it in your cervix, kind of like a pap smear, and then we fill it with water. That's the one that we do most commonly, known as a saline sonogram, which we'll walk into. Or you can do what's called an HSG, hysterosalpingogram, and we'll talk about those a little bit later. But let's tie the picture together. How do they all work? So we spoke about the eggs, we spoke about the tubes, and we spoke about the uterus. So on our period, our body recruits our antral counts, meaning everything's at home base, our lining is nice and thin. Then our body starts making food to grow the egg. That egg, remember, makes estrogen. That estrogen has two purposes. It will grow our lining and it will start signaling to the brain, okay, I'm getting ready, I'm big. Then our brain switches and makes LH, which then causes ovulation. And that cyst then remains to make progesterone. That progesterone makes the lining nice and sticky for implantation. If we're not pregnant, that cyst will go away. If you look, it starts becoming nice and gray. Then our body notices, okay, there's no more progesterone to support my lining, and then everything sheds and you get a period. So for fallopian tubes, they're not working, meaning if they're damaged or if they're swollen, typically they can present with water in our tube, which we call a hydrosalpinx. Anything inflammatory or previous surgeries can damage that. And we'll look with an HSG or an SIS, which we're going to talk about. Our lining also needs to respond to this estrogen and grow nice and thick to implant. Ideally, we want it between 7 to 8 millimeters or thicker. And then we want this progesterone to make it nice and sticky to latch onto this embryo. What can be in the lining that can prevent implantation? So typically, this is known as uterine factor infertility, meaning in the uterus, there's fibroids or polyps that can prevent implantation of this tiny little beautiful embryo. Polyps, we usually take out with what we call a hysteroscopy. Fibroids, if they're outside of the cavity, we leave them alone. If you have scarring known as Asherman syndrome or abnormal uterine shape, like a bicornuate, then we talk about that. Usually uterine abnormalities, besides the septum, we don't operate on. Okay. And that with that saline sonogram, it does, because we are dilating and inflating that cavity, we recommend taking Motrin or any painkiller about an hour before you come to your appointment. We're looking for, the first one is a septum. So if you look, we're made in like a line, and then our body folds in half. So we have two eyes, two nostrils. You can see our lips kind of meet right in the middle. Just like that, our uteri fused together, and a little Pac-Man eats the middle line. So if the Pac-Man falls short, then it becomes what's known as a uterine septum. And usually patients with a septum present with recurrent pregnancy loss. They keep miscarrying. Asherman's is from previous surgery or miscarriages. And then a bicornuate septum is when the Pac-Man from the top failed to kind of chew and fuse them together. So you have two separate uterine cavities. Next slide. What about the sperm? So males are lucky in the fact that they can reproduce sperm every 70 to 90 days. So every 70 to 90 days, they're born with stem cells, so they get a whole new batch of sperm. What we're looking for is at least 15 to 20 million. We want at least 40% moving forward. That's called progressive motility. And we want at least 4% to be shaped normal. Other factors we look at is we want to make sure there's enough volume, thickness, and then that's the viscosity. And we want to make sure it's a normal acidic level. And we also look at the sugar concentrations. The best time to do a semen analysis is after abstaining for 3 days. It's okay, Sydney, but no more than 5. So we get a fresh sample. Now, if we find anything abnormal, or if we have a reason to believe that we may have an abnormal semen analysis, we have male urologists or urologists that focusing on male health to look at other factors like DNA fragmentation, which is small breaks in the tail of the sperm, CAP score, pyospermia, meaning infections in the sperm, and then male fertility hormones. We also recommend that both partners do genetic testing that is now looking for diseases in your family, and then infectious disease as regulated by the FDA. And then we do offer a scrotal ultrasound to look for any abnormalities. So other required testing that we'll do at the same time is we want to make sure you're up to date on your pap and physical, because we want to make sure that there's no cervical abnormalities or breast follow-ups that we need, because once you're pregnant, it's harder to do, God forbid, breast cancer, any colon biopsies that your cervix needed. We will also look at all of your other endocrine hormones, because thyroid abnormalities can cause miscarriages. We want to make sure we look at your infectious disease for you and your partner. This is now an FDA requirement. We offer genetic carrier screening for everybody, and it's an opt-out. We want everyone to do it. If you don't want to do it, we have you sign declinations. And then we want to make sure your vaccination titers are up to date, because remember, your body will protect the baby and your immunity will protect the baby for up to 6 months when they can start getting their vaccines. Next slide. So genetic carrier screening is very different than abnormalities in the uterus. So genetic carrier screening is what you carry from your family that you can pass on. Now, you may just be a silent carrier and your partner may just be a silent carrier. But remember, when these two little, I call them Lego pieces, get together, you make a big Lego piece. And when you step on that, that hurts. So just like this, when you get two little pieces coming together to actually make a disease, then you can have a sick baby. So it's kind of a gamble. If you're carriers of the same diseases, then there's a 1 in 4 chance, a 25% chance you'll have an affected child. Now, for me, that's a big chance. So if you can gene eliminate that if you, God forbid, test positive for the same thing. Other factors that we want to make sure that we cover are healthy BMI. Now, here at Kindbody, we won't ever say you're not within our BMI, we can't do any treatment on you, but we want to be mindful that a normal BMI or a healthy BMI between 18 to 25 will optimize our outcome when it comes to miscarriage, not necessarily retrievals. The higher, I think 35 and above has a slightly higher miscarriage rate, about 20%. Zika still does exist, so just be careful where you're traveling. I know we're not tracking it with the CDC. I'm a patient as well. I did go to Mexico a couple of times because I think mental health is also very important, as long as you're mindful and understand the risks. Next slide. We do talk about supplements. So if you go on our website, there's a slew of supplements that we do offer. Supplements are well studied in an animal model. So when patients say, should I be on it for X number of time before I actually pursue treatment? The answer is no, because remember, age and time dictate our fertility outcome. This is something we want to do additional. So I'm a huge believer in supplements, oxidative stress, and improving our outcome, but there's no exact timeline that you need to be on it to notice an improved outcome. Okay. And it's also really important to look at what are your short-term goals, right? Most people, by the time they see a fertility doctor, they wanted to be pregnant yesterday. So short-term goal is getting pregnant. And then long-term goals is, what does your family look like? Do you want more than one child? And believe 75 to 80% of couples want 1 to 2 children, more than one child. So what does that look like? How does your time play a role in that? And I think that's huge, because remember, infertility doesn't go away. You will likely need to come back for baby number 2. And maybe time and age won't be on our side. So do we bank embryos now as opposed to crossing that line when we get there? Okay. So what does it mean to be infertile? I don't know about you guys, but I remember feeling very isolated, like it was only me that it's affecting. Recent data shows actually 1 in 6, 1 in 8 is proven couples suffer from infertility. 1/3 of infertility is actually due to male factors. So it's not just one person. And then if you look at the other 1/3, it's a culmination of both. And then the other 1/3 is female only. If you're 35 and over, after you've had unprotected intercourse, notice how I'm not saying trying, because most people say, well, I wasn't doing OPKs. We weren't really trying. It's just unprotected intercourse for 6 months or longer, then you merit a full fertility workup. Okay. So now what is IVF? IVF stands for in vitro fertilization. So it's amplifying what your body has recruited for that month. So remember earlier, we said your body has an antral follicle count of between 6 to 8 follicles on each ovary, but you naturally make only enough food or FSH to grow 1 egg. In IVF, we give you synthetic forms of FSH now to grow all of those eggs so we can retrieve them and hopefully give you more chances of take-home baby. Okay. So it's taking injection medications for 10 to 14 days. It's doing blood work and ultrasound. We call it monitoring every third or fourth day. And when your follicles are ready or mature, kind of when you would be ovulating naturally, we give you a trigger shot to release them. So one of the most common misconceptions is I'm going to go to menopause sooner, or you're taking all my eggs out. We're not. We're only taking what's been activated for that month. Either you use it or you lose it, and we're not going to stimulate anything that wouldn't happen naturally. So naturally, the rate limiting factor is FSH. So if we give you more food, then we get more chances, more eggs to create fertilization and hopefully an embryo. Okay. Every Monday, we do what's called Med Teach and Mocktails, where we go through the medications with you step by step on each medication. How do you take it? You can sign up on our website. It is quite overwhelming. I do this for a living, and I remember every time I get a box, I get overwhelmed. So one of the biggest things I do is separate what I need now versus later. Make sure you do a med inventory, because remember, the pharmacies may not dispense everything that we've prescribed, and then join our Med Teach and Mocktails to understand how to administer this medication. Okay, how does a retrieval work? This is something that you can also see in our Engage MD portals, or you can go on my social media or the Kindbody social media. We have videos of it. It's about a 10 to 20 minute procedure. You go to sleep under light IV sedation. Once you go to sleep, we do an ultrasound. At the tip of our ultrasound is a little needle, which sucks the eggs out. It's like a straw. Then the embryologist counts the eggs. When you wake up, you'll know how many eggs we took out. The next day, you'll know how many were mature and how many fertilized. Remember, not all of our follicles have eggs. Typically, we expect 80% of our follicles to have an egg in there. Next slide. So that same time, we'll use sperm to fertilize the egg. That's a process known as ICSI, intracytoplasmic sperm injection. Remember, even if we're forcing the egg and the sperm on a day, it doesn't mean it has to fertilize. Only about 70% of these eggs will fertilize, and only about 50% of these eggs will then make it to an embryo. Then you can send them off to genetic testing at what we call a blastocyst stage. A blastocyst is an embryo that's separated into two cell layers, baby and placenta. When you do a biopsy of a blastocyst, we freeze the embryo here at a Kindbody clinic, and then the biopsy goes off for testing to a special genetics center. Depending on your age, 50% or more of your embryos can be abnormal. Okay, next slide. How do we know if your embryos are healthy? So PGT trumps everything. Once it's a PGT normal, morphology, meaning the grade or appearance, doesn't matter as much. Appearance does not correlate to PGT. It could look beautiful, but it could be abnormal, and we usually don't transfer those embryos. Okay, chromosomal content is exactly half egg, half sperm fused together to make one unique baby. The goal is to hopefully, with PGT, lower miscarriage rate and decrease the interval to a successful pregnancy. It may require more than one IVF cycle to yield a pregnancy, and that also is based on age. Okay, next slide. What are the benefits of PGT? It counts the number of chromosomes. And if you say two big points are it decreases the interval to a successful live birth, and it decreases the risk of a miscarriage. For me, that's huge. And it's about 90% accurate. So once you're pregnant, we do recommend further testing, but I will take that 90% because that is huge. Next slide. So why do some couples not choose PGT? It does require micromanipulation, meaning a biopsy of the embryo. Most couples opt not to do PGT because they either have limited number of embryos or financially can be costly. Next slide. I think this is the most important slide, at least for me. It was a shock because you get X number of eggs, and then you think automatically all of those eggs will then be a baby, that you're not going to undergo that attrition. But know that this is very normal. Even when you take age out of it and you take a donor egg, they undergo the same attrition. So not all of our eggs are meant to be embryos. Not all of our eggs will be mature. Not all of them will fertilize, and not all of them will make a blastocyst or test normal. You need at least 3 tested normals independent of age to have a 95% chance of one live birth. Okay. Fresh versus frozen. So fresh embryo transfer basically means we do an egg retrieval. We wait about 3 to 5 days in between, and we put the embryos back in. Frozen embryo transfer is when we take the eggs out, we create embryos, you wait for a period, and then we prep your body to do a transfer. Frozen embryo transfers have a slightly higher increased success, just because if you can focus on one thing at a time, like if I focus just on your eggs, then just on your lining, you can optimize the outcome, okay? Why do we recommend an FET? Because it gives you time to recover physically. It allows for us to focus just on your lining to sync the embryo to your uterus. And then you can allow for genetic testing, because remember, that's a send out test. Next slide. We give you a calendar with ways to build your lining. So we'll give you some estrogen for 8 to 10 days. Then we'll add in progesterone and oil, and then we do the embryo transfer. You stay with us till you're mid to late first trimester, between 8 to 10 weeks. Then we do our OB exit, and then you go off to your OB. You will stay on all of those medications up until you're 10 weeks. That's when the placenta kicks in, then you don't need any of our medications. So how does a transfer work? You don't go to sleep with this. We have a thin, flexible catheter, kind of like our saline catheter. We slide it up top in your uterus, we deploy the embryo, and then we, fingers crossed, it latches. It's about a 10-minute procedure. We do give you a Valium to kind of help you relax your nerves more than anything. And it also helps because we use your bladder as a window to look inside when we slide the embryo in. We do offer acupuncture at most of our Kindbody locations, a session before and after. The data on acupuncture, the premise behind it is to help increase blood flow to keep the embryo nice and sticky. Next slide. So kind of a summary of all our treatment options. We can take a fertility medication called Clomid or Letrozole, and TIC means timed intercourse, or IUI means intrauterine insemination. Essentially, it takes 1 month where you take an oral medication, we time your ovulation, and we either put the sperm right up top or you have sex at home. The chance of success with that is about 10 to 15% per cycle per month. I like to, for me as a patient, I like to flip it, because I remember when I was doing this and I would get really upset it didn't work. It was a good reminder to say, okay, there was an 80% chance this was not going to work. IVF without genetic testing is about 40 to 50% on an average 35-year-old per transfer. And then IVF with genetic testing bumps it up to 50 to 65%. These are national numbers. Now, this is really important for expectations, sorry, Sydney, is how many cycles does it take to get to baby? IVF, although it seems like the big gun, like I'm doing IVF, I'm going to take home a baby. Remember, not all of our eggs are meant to make an embryo or meant to make a baby. The older we get, we may require multiple cycles for take-home baby. Next slide. Sorry. So it's important to remember the path to parenthood isn't always linear, and it definitely doesn't start off how we envisioned it, right? There's a lot of bumps in the road, lots of ups and downs, and we're really big on making sure your mental health is okay and that there's psychological support offered, available through Kindbody 360. Next slide. There's also the option of donor egg, donor sperm. Okay, we do have an in-house donor egg bank. We have donors that have already previously donated, so you can purchase a lot of eggs. We recently started surrogacy as well. So if the implantation's a factor, then we look and talk about surrogacy. Next slide. How do you pick a donor, whether it be donor egg or donor sperm or donor embryo? So donor egg and donor embryos you can do through Kind EOS. We have identified or de-identified or non-identified. That's the new nomenclature per ASRM instead of anonymous or non-anonymous. And we could do fresh versus frozen donor egg, meaning someone's previously donated to the egg bank, or somebody you guys want to hand pick that kind of resonates with you. Donor embryos are embryos that have previously been created, and then their family's complete, so they donate to kind of pay it forward. We don't have donor sperm, but we do have a list of agencies that we work with that you can pick donor sperm options. Selecting your carrier, whether it be you, a surrogate, or a partner. We do a lot of reciprocal IVF, and I think it's absolutely beautiful. We're in a same-sex female relationship that it's the egg of one parent and then the uterus of the other parent. So they're both very intimately tied to this process. Next slide. At the end of the day, there's no magic formula. Remember, everyone's body's different, everyone's cycle is different. And this is not meant to kind of take away, but you could do the same thing twice and get two very variable results, which tells us that there's still a lot of unknown to this, and it's not a perfect science quite yet. And the best way to make a decision is to really understand what works for you, what works for your body, and make sure you talk to your doctor, be very open. That's something that we really hone in on at Kindbody, is that let us educate you so you can make really well-informed decisions together with your provider.